Hi everyone, I'm Kat Livingston, Medical Director of HealthShare, and I get to talk to you about our initial findings and lessons learned from a Medicaid housing benefit pilot. So our agenda, first I'm going to give you some background on our housing benefit pilot, a brief overview of the overarching evaluation that we're doing to evaluate this innovative pilot. We're going to dive into some program data in terms of baseline needs and service utilization. And then we have learned a lot. So we're going to share our implementation experiences and finally some key takeaways and next steps. So the HealthShare Housing Benefit Pilot. I think everyone in this room recognizes that there is a relationship between housing and health. And this is something that's very old information for a lot of people here, but it's fairly sort of new information for a lot of Medicaid payers who are really trying to get into this space right now. So there are a lot of states with 1115 waivers really trying to explore how we can leverage health-related social needs in order to support Medicaid members' housing and security needs. So Oregon actually, through our 1115 waiver, adopted health-related services, including a housing benefit as of November 2024, so 2 months ago. But this pilot precedes that. For the past 2 years, between 2022 and 2024, my organization launched this housing benefit pilot in anticipation of the waiver. So just for some context, so HealthShare of Oregon is Oregon's largest coordinated care organization, which is the Oregon flavor of managed care or accountable care organizations, but kind of different and pretty awesome. And so the one I work for is the largest CCO in Oregon. We serve about 450,000 members, and it's in the Portland metro area and incorporates 3 counties. So Oregon is unique, and then our CCO is unique because we like to be unique. But one of the things that's quite interesting about our CCO is that it incorporates all the major health systems in the Portland metro area. So Kaiser and Providence and Legacy Health and Pacific Source and Oregon Health and Science University are all part of our consortium, as well as Care Oregon, which is our integrated community network and provides specialty behavioral health, dental, and NEMT. So here's our pilot that HealthShare created. So really we wanted to provide a temporary assistance program through our CCO, and the initial intent was really to reduce the amount of time that people spent in houselessness or prevent houselessness altogether, as well as improving health outcomes. And I think one of the super interesting things as we're learning about what different states and different payers have implemented is really figuring out what the menu of benefits are, because we're all pretty different. So our menu of benefits included housing navigation, hotel motel stays, move-in support, monthly rent support, past due rent payments, move-in fees, all the utility things, including back payments and ongoing payments, and then home remediation services and some others. So this is different than what some other states have chosen. For example, inclusion of rental supports is quite different. The hotel motel stays is different. And we had a pretty broad benefit offering this menu. So I think one of the exciting things is because this is really new, like we had this opportunity to feel like, to explore what is it that people actually need when we have this broad menu. And then the participants would experience housing navigation through community-based organizations, as well as health plan care coordination. So they had sort of a multidisciplinary team to support getting these housing benefits. So the pilot, so we decided the people who would be eligible for the pilot were first those who are either experiencing houselessness or at risk of houselessness. And so that's really critical because that's quite different than what we're rolling out now, which is, so there are some learnings there, which I'll share in a moment. But then we also decided that there were 8 priority populations based on discussions with we had our regional supportive housing fund that had people with lived experience and housing providers. We had our clinical advisory panel who all helped us land on these priority populations. And so the phase 1, which launched in May of 2022, included people aging out of foster care, those leaving substance use disorder residential programs, and those leaving corrections. In phase 2, we were able to expand the pilot. This was in late 2022 to recuperative care programs, as well as to inpatient settings. So there are actually only 2 programs in inpatient settings that were applicable. So one was Project Nurture, which is an integrated maternity and addiction care program. And if you haven't heard of it, it's totally awesome, and I highly recommend Googling it. And then the other one was an addiction consult service. So many of you may be familiar with the IMPACT program, which is out of Oregon Health and Science University. And then in March 2023, we paused our pilot because we hit a capacity wall. And we were no longer able to effectively get people navigated to housing services. So we stopped it and did a pretty significant reframe rebuild of our housing pilot. We never ended up launching our final phase 3 populations. We changed the benefit from 12 months to 6 months. So initially we had decided to do a 12-month benefit. In the meantime, the state of Oregon was actively developing the 1115 waiver and was clearly indicating that it was only going to be a 6-month benefit. So we adjusted our benefit to be from 12 months to 6 months. And then the final thing is we had included people who were houseless. And we learned that that is not a population that we can really help with 6 to 12 months of housing support. And also the state was deciding to only include those at risk of houseless for eviction prevention. So we narrowed our benefit to really align better, or to align with what the state was intending and the fact that we hit this wall of capacity. And then we reopened the benefit just to 2 groups, the aging out of foster care and then the substance use disorder residential programs, and then have wrapped up this pilot as of November of 2024. So we have a very exciting mixed methods evaluation. I have colleagues here from Providence CORE, which is the Center for Outcomes Research and Education, who are doing this evaluation for us. And so first we wanted, this is really novel and innovative, and we wanted to figure out how we were doing in terms of the pilot, what are things that we need to improve as we embark on this new adventure. I'm just this is kind of obvious, but we learned it again, is that Medicaid is really complicated. We knew that part. Healthcare is really complicated. Everybody knows that part. And who would have thought housing is also super complicated? And so if you put those 3 things together, you end up with chaos. We have a lot of learning, and building those multi-sector relationships across plans and health systems, and then the housing organizations and counties, it's super complicated. So we really wanted to understand how we could do this well. So the process evaluation, the parts we're going to talk about today are the results of the staff interviews and the program data. And then some of the outcomes evaluations, so we're looking at participant experiences. We have a client survey and interviews that we've just wrapped up. And then we have a cost evaluation where we're looking at health outcomes, including claims and costs. So those are in process, and today we're doing the middle green column. All right, so in terms of baseline needs and service utilization. So this slide provides an overview of who is served by the pilot. So of the 715 individuals who were referred, 517 were enrolled. The demographics, the majority of the participants were male, white, and residents of Multnomah County, which is our biggest county, and nearly all participants were English speakers. So when we designed this pilot, one of our key concerns was an equitable rollout, and really trying to make sure that we weren't sort of differentially not reaching the populations that we were hoping to. And so we did do a comparison looking at those enrolled versus non-enrolled, and there's no difference in demographics, so that's reassuring. And a lot of the people who didn't end up enrolled either weren't HealthShare members, so word had kind of gotten on the street where people were trying to get access to this housing benefit, but weren't actually members of our CCO, and then some weren't part of the priority populations. And then in terms of who were enrolled from priority populations, so we had 48% from substance use disorder residential programs, 20% from corrections, 12% aging out of foster care, 10% in our recuperative care programs, and then 8% from Project Nurture, and then the rest from other settings. So this is providing an overview of the health, housing, and social histories of the participants at enrollment. So we had 87% with a history of substance use. This makes sense given the priority populations that we chose to focus on. 57% had a mental health diagnosis. 44% had been in the emergency department or hospitalized in the last year. In terms of housing history, we really wanted to also try and figure out, are people already connected to housing or not? So we did a lot of evaluation in order to really understand what their engagement was or wasn't. So 32% were already on a housing wait list, 20% had property or utilities debt, and 16% had an eviction in the past 7 years. In terms of other social history, 71% had been convicted of a crime, 32% were employed, and 23% had transportation issues. So just to pull out one of the things about this baseline history with the history of eviction and the history of crime convictions, that actually, obviously that impacts potentially people's ability to be housed. And so this is just really important in a lot of the learnings of the pilot too, in terms of finding landlords for people who had histories that can often end in discrimination against their ability to maintain housing. So here's the program data. This is very exciting. There's a lot on here. So first, the left column are the menu of services that we offered as part of our housing benefit pilot. The second column is needs. So this is at enrollment, what people identified that their needs were. The next column is utilization. So what percentage of them actually ended up utilizing each of those benefits. And then the final column is expenditures per member per month. And I get to wear a payer hat, and so actually figuring out what this stuff costs is super relevant as we're exploring that. And when we think about North Carolina and Massachusetts, all of us have chosen different benefits, and so really understanding what it costs to administer these services is super important. So in terms of highlights from this, the highest reported needs at baseline were rent support, move-in fees, move-in support, and utility assistance. The most access benefit was navigation services at 91%. It should have been 100%, but that's okay, because it was built into the pilot. And then one of the things to really highlight here is that for short-term hotel motel stays, only 16% said that they needed it, but 33% ended up using it. So it really potentially suggests a misalignment between needs and what we ended up providing for them. And then if we skip to the last column, the expenditures. So looking at what's most expensive, so short-term hotel motel stays were the most expensive at $900, like basically $1,000 per member per month for people who are accessing hotel motel stays. The second most expensive was the housing monthly rent support at $966. And then the third most expensive was the housing navigation support and sustaining services at the $402. And then the crazy squiggly lines are fun, and you don't have X and Y axes to really understand it, but what we really wanted to understand is over the duration of the pilot, how do those costs change? And so this, without axes, it gives enough information to show, some of these things are expected. So the things that are high cost at the beginning of the pilot are things like housing move-in support and move-in fees. The short-term hotel motel stays are really high, and they taper off over time. And then other things grow over time. So for example, rent support, that was a continually increasing cost over the course of the pilot. So this is just as we're figuring out what our fee schedules are and what we're gonna be paying for and what the true costs of all of this is just really incredible data to understand what these things actually cost. And then I'm super curious to really compare this to North Carolina and others and figure out, we have different benefit packages, but really understanding what it is that will allow for sustaining these services is critical. All right, so now I'm gonna pivot and get into our implementation learnings because we knew that this was going to be a lot of learning as we stepped into the space. So we conducted staff interviews, 32 interviews in total from 18 unique organizations. And the purpose of this was really to understand, as we're implementing this one of the many novel pilots in the US, what are the experiences of staff who are implementing it in terms of processes, in terms of their vision for the benefit, their experiences, what we need to do differently, what supports we need to offer. And this was going to inform our pilot implementation as well as the 1115 waiver implementation by our CCO. And then we analyzed it in the normal ways. Sorry to my core colleagues. Analyzed it in the normal ways. They did an amazing job of systematic and thematic coding and all that stuff. The normal ways. Okay, good. All right, so in terms of those themes that we did in a beautiful qualitative analysis, the three themes were really around shared vision and expectations, program infrastructure, and training and support. So for shared first, I mean, people really appreciate that Medicaid is stepping into this space and offering a housing benefit. Like, this is awesome. So just as a foundation, like, we learned a ton, and there's a lot of constructive criticism that came out of this work, and there's a lot of excitement about the opportunity here and really profoundly changing people's lives. So now we'll get into the constructive criticism part of things. So in terms of shared vision and expectations, there were a lot of questions about what is the benefit actually trying to achieve? Is this a short-term payment support? Is this housing navigation with wraparound supports? Is this connection to permanent supportive housing? And that changed over the course of our pilot. Initially, we thought we could help connect people to permanent supportive housing. The answer is no. It typically takes, for someone who's chronically homeless, a 3 to 5 year time frame to get somebody stably housed. And that is not what this pilot or our benefit is offering. So there were a lot of learnings there. Understanding more up front what it is we were trying to achieve would have been helpful, but we were also figuring it out. So I think it's fair that was a learning process. And one of the key questions is how this benefit situates within the larger housing landscape in Oregon. Like, what is our role as a Medicaid payer versus the role of the entire housing infrastructure and all of the counties in their work? And we still need to continue to figure that out. So that we're not just our own program that's separate from all of their work, and we're prioritizing people that are different than what the housing organizations are prioritizing. So making sure we have an aligned prioritization so that we're not just being like, hey, how's all our people? And they're like, actually, those people don't make it onto our priority list. So that disconnect was pretty powerful and made it very difficult for us to potentially get people housed who are not necessarily already prioritized on the housing side. And then the other thing, there are some really simple things here. So we, by the end, and now with 1115, we're offering a 6-month benefit. So I think all of us know when you sign rental contracts with landlords, it's typically 12 months. And so there are a lot of landlords who are not willing to say, hey, I've only got guaranteed 6 months rent. I'm not going to sign a 12-month lease. So even really, it seems simple, but that's a huge barrier to actually getting people housed when our benefit misaligns with what standards are in the housing community. And then moving on to program infrastructure, we made a lot of changes. This was like a build it as it's going sort of thing, which was part of the awesomeness of being able to have this really flexible pilot. But there were opportunities for better communication, for transparent decision-making. As we made these pretty significant shifts, we could have done a better job of being very clear about what was changing, changing our documentation processes. So we got a lot of really great feedback about that. And then one of the key issues with that we learned is that when you're paying rent, as everyone knows, it needs to be on time. And Medicaid payments are historically not the most efficient and effective, and non-bureaucratic administrative thing. And so we had issues where sometimes those payments would be a little bit late, rent checks would be late, and it really put people at risk of eviction. So potentially harming and traumatizing the very people that we were trying to help. So really trying to figure out how do we streamline and not create administrative burden and get those checks out on time so that nobody is ever threatened with eviction because we failed to get them checks on time. So that was important learning. And then with training and support, we had a wide variety of community-based organizations doing the housing navigation, and there was a lot of variation in experience among those different CBOs and housing navigators. And there were also really different caseloads. So some had caseloads of 70 and some had caseloads of 2. And so we really needed to create sort of standards around what is a manageable caseload, what's an appropriate caseload, and then really offer a lot more training because there were people with very different levels of experience who were working on this pilot. So we initiated a community of practice to really create standards around training and caseloads and things like that, and that was highly valued, was this community of practice. So I've got a couple of quotes here that you can look at future time, because I have a big yellow card, seeing 1 minute left. So I'll just go through key takeaways and next steps. So this pilot provided much needed housing supports for more than 500 people, which is pretty awesome. And I would say we have a ton to learn about what is our role as a Medicaid payer, the health system's role, and housing, and figuring out how we can better synchronize or interdigitate, if you want to get all geeky with me, our work and their work. So for the next steps for the evaluation, we're actively evaluating participant experiences. We're doing our claims and cost utilization. So in addition to the PMPM, finding out, did we decrease emergency department visits? And did we decrease admissions? And did we increase substance use disorder engagement, which was one of the key goals? And finally, we are implementing the 1115 waiver as we speak, starting as of 2 months ago. So really taking these learnings and implementing that into the waiver. All right, thank you.